I'd like to welcome you all to Memorial Medical Center. So glad you came tonight. We have a wonderful program for you titled Advances in Joint Replacement Surgery, a Team Approach. My name is Jennifer Perkins. I'm the program coordinator for orthopedic services at Memorial. If you haven't done so already, please help yourself to refreshments over there on the side. I will get rid of a couple little house cleaning items. There's a bathroom located through the doors and off to the left if you need those. You all are in for a wonderful treat tonight. We have a great panel of speakers who will discuss how patients, physicians, and hospitals are going to partner together to get best outcomes for their patients. Tonight's speakers include Dr. Scott Sotovia, with Associated Anesthesiologist of Springfield, Dr. Dan Adair with the Orthopedic Group at Springfield Clinic, Dr. Leo Ludwig with Orthopedic Center of Illinois, and then Dr. Cal Sala with the Department of Orthopedics at SIU Healthcare. After the short presentations, we'll have plenty of time for questions and other discussions, so please take advantage of that and of this wonderful panel that you have here today. And before I ask Dr. Sotovia to start things off, I'm going to sneak in just a few minutes to tell you a little bit about our JointWorks program at Memorial. We started JointWorks, which is a program for hip and knee replacement patients, almost 9 years ago. Late next month will be our 9-year birthday. And I receive tons of letters from people on a weekly basis that talk about their experience going through the program. I'm going to share just one with you. I'd like to start by saying thank you all very much for what you have done for me and my family. I feel much better already. I am able to walk with my children and have a better outlook on life. Everyone involved in my surgery and recovery were great. You have the best nurses. I stand straighter and I walk better. Again, I can't thank you all enough. Keep up the wonderful job. You're changing lives for the better. That last part really makes me smile because that's why we're here. That sums it all up. We want to change lives for the better. That goes in line with our mission at Memorial Medical Center, which is to improve the health of the people and communities we serve. And we have a pretty clear vision as well. We want to be the national leader. We want to be the best. We want you to come here for your hip or knee replacement, and we want you to receive the best care possible. We've experienced significant growth over the last few years. Nearly 800,000 people in the United States have hip or knee replacement surgery every year. 1,500 of those come to Memorial. We want to ensure that each one of those patients get the great patient experience. We invite our patients to attend First Steps. That's a new class that we offer, taught by an orthopedic surgeon, currently Dr. Adair, which you'll meet in a few minutes, and a physical therapist. They really are going to give you the how-to optimize yourself before surgery. They're going to tell you how you can improve your physical, and your mental condition. It's kind of the playbook on what you need to do to get ready for surgery. Now, this class is open to any orthopedic surgery. You don't have to be having a total joint replacement because everyone can benefit coming through this prior to a surgical procedure. We also invite all of our patients to attend an education class. Jackie Davis is the JointWorks educator. She's back in the back at the JointWorks table, so say hello to her if you'd like to. But she covers a variety of topics so that people going through this program, our JointWorks program, are going to understand what they can expect before, during, and after. Knowing that up front really relieves some of the anxiety that some people experience with a surgery. We also take a wellness approach. Now, joint replacement is tough. It's not easy, but the efforts are very well worth it. We're going to get you up and going right away. We want you to get up and we want you to keep moving, and we're going to show you how to do that. We have had a couple of very nice national awards presented to our JointWorks program, and the awards are nice, but what they really do, they serve as an external set of eyes that look at our program and tell us that we're doing the right things for our patients. We have the Blue Cross Blue Shield Center of Distinction for our hip and knee replacement program, and the Joint Commission. Now, I'm not going to lie, I am a little bit proud of this Joint Commission award. That one was really nice. Our representative from the Joint Commission came to our hospital. They looked at our program, every little piece of it, to make sure that we were complying with the standards that have been established as the best. Okay? And then they gave us this award. We're only one of 9 hospitals in Illinois who have achieved this. That's quite a remarkable feat. We also, more importantly, we want to look at our patients. We want them to tell us that we're on the right track. And so Jackie, who I mentioned before, she calls all of our JointWorks patients a few days after they go home, and she asks them a variety of questions. One of them, did we meet your expectations with regards to service while you were here in the hospital? And as you can see, over time, we have very strong results. Another question she asks is if we have met their expectations regarding pain management. I think pain is one of the common fears in people getting ready to go through a joint replacement program. So our job is to educate people ahead of time so they know what to expect. None of us are going to tell you that you're not going to have any pain after surgery, but we are going to tell you how best to manage that pain. Another thing that we take a look at, we collect a lot of good data, and it's very helpful to us. One of the things that we look at is where our patients go when they leave the hospital. When you combine that big red chunk, that's the people who go home, directly home and they have a therapist that comes to their house, or they come home and they have and they start going to outpatient therapy, or they go home and they don't need to require services for therapy. That combination is 88%. So 88% of our patients are ready to return directly back to their home after they leave the hospital in about 2 days. That's the average length of stay after this surgery is 2 days. Now this is pretty good because of our peer group. So our other hospitals of the same size and teaching hospitals, only 65% of those patients are ready to go home. The rest of them go to an extended care facility or nursing home for a short amount of time. We think that if at all possible, we want to get you back in your own environment. So that's what we strive to do. Another thing that we've just started is a joint replacement registry. Now they've been doing registries in Europe and Australia for more than 10 years, and finally the United States is on board, and they've started their registry within the last couple of years. But the purpose of a registry is to be a center for data collection and research, and it has tremendous benefits to society as a whole. It improves quality, outcomes, and cost effectiveness. Now we have our own internal registry, so we're gathering our data so that we can benefit our patients directly, but we're also submitting our registry data to the American Joint Replacement Registry, and we're only one of 32 hospitals that are currently doing that in the United States. When we're looking for opportunities to improve our program, we do not overlook the biggest resource out there, and that's people who have been through the surgery themselves. We have a patient and family advisory panel. This program is phenomenal. These group of individuals, their patients and their spouses, they get together periodically, every other month to be exact, and they really utilize their unique perception as a patient or a family member of a patient who's been through the process to guide us into what we need to do next. How can we make improvements? They're the perfect ones to let us know. So our next step, that's the one thing that I like about the JointWorks program and about Memorial in general. There's always a next step. No one ever sits back and says, okay, good enough. It's always, how can we make things better, and what can we do to make improvements? So we're going to continue with an orthopedic co-management program, and that's where hospitals and physicians, they really can work together to achieve those common goals for good patient outcome. Of course, we're going to draw in those patients. We're going to get their ideas through surveys, phone calls, and the advisory groups. And then we utilize at Memorial a Six Sigma program for process improvements. Now, this was not started in the healthcare industry, but certainly applies, and it's a very structured approach to making improvements. And what this does, it's going to help us. Our aim is a error-free performance, and that's of course what we're going to be shooting for. So a lot of our doctors have gone through a Six Sigma program. A lot of our hospital members or staff members have gone through various levels of Six Sigma program, and we're looking forward to seeing what other projects we can use to use this process to make improvements. And then most importantly, just like the gentleman said in that letter that I shared with you at the beginning, we're going to change lives for the better. Again, that's why we're here. That's what we want to do. So thank you for letting me tell you about the JointWorks program for a few minutes. Next, I would like to introduce Dr. Scott Sitovia. He's an anesthesiologist, tremendous resource for our orthopedic team, and he's going to talk about pain management. So thank you.
Good evening. As Jennifer said, my name is Scott Satovia. I'm one of the anesthesiologists here at Memorial, and I'm in charge of the orthopedic anesthesia program. And I've been here now going on 7 years, so things have changed quite a bit since I started off here with the JointWorks program, and I think we've done a pretty good job of improving things and having really good outcomes with folks that have joint replacement surgery. One thing that's really important with this process is the teamwork approach that we have to anesthesia and patient care in general. This is just a list of the 6 people that are involved in the operating room, but you're going to meet a bunch of other people too that are up on the floors, the therapists, pre-admission, all throughout the hospital that have an interest in this type of work. Things that we're doing specifically down in the operating room is we have a smaller team of anesthesiologists that do these cases, a smaller team of CRNAs who are nurse anesthetists that are involved with these cases as well. So you have people taking care of you that have an interest truly in doing the joint replacement cases. The reason that we do this is because we want to provide you with the best and the safest care. Specifically for anesthesia, that usually means what's going to get you out of bed the fastest, most comfortable, so you can participate in your therapy and get home and continue with your rehabilitation. We want an anesthetic that's reliable, has minimal side effects, and consistently makes folks happy. What we've found and what others have found in literature is that a regional anesthetic, which is a spinal in most cases, is the best thing for your joint replacement surgery. And most folks are kind of scared when they hear that I'm going to have a spinal anesthetic because they've heard stories about people being paralyzed or nerve damaged or anything like that. That may have been true a long time ago, but anymore the spinals are just as safe, or if not safer than a general anesthetic, which is what most people are familiar with. And the general anesthetic is the anesthesia when you're all the way asleep with a breathing tube a lot of times. And regional anesthetic, we just put part of your body to sleep. So part of the benefits of the regional anesthetic are reduced blood clots, which is a big deal after orthopedic surgery. You have less blood loss during surgery, so you're less likely to need a blood transfusion. They have less wound infections, less nausea. And the thing that most folks are interested in is their pain control is going to be better right after surgery, and actually long term. There have been some studies out there that have shown if we reduce your pain after surgery in the acute phase in the first few hours, we can actually reduce your long-term pain too. So spinals are great at doing that. The advantage really of spinals as well is that we can avoid the breathing tube and the ventilator, which for some folks that's a big issue. You're pretty likely to get sick with general anesthesia and pretty unlikely to get sick with the spinal, so we like that. General anesthesia, you wake up right away at the end and it's going to hurt. The spinal is not quite like that. It wears off very slowly over the course of a day. So as you start to have some pain at the end of surgery and your recovery time, you can start working in those pain medicines and start feeling better about things. The other thing that we can avoid with the general is a lot of memory problems arise for some reason as we age with general anesthetics. We don't know why, and we don't know how to prevent them, but for some reason, even up to a few months after surgery, some patients say they still have trouble thinking after they've had a general anesthetic, so we can avoid that with our spinals. But that's not to say, of course, that you're not going to receive some sort of sedation during the operation, because we want you to be comfortable. And the way that we do that is we use some IV medicines, and we give hopefully the right amount to you to make you forgetful, nice and relaxed, and not care about things for the couple hours that you're in the operating room. But the amount that we give you can be affected by a few things. Some folks don't tolerate a lot of sedation. People with sleep apnea, with certain specific health problems, we have to limit what we give you, because the bottom line is we're there for your safety, and we want you to be safe and get through surgery and be able to get on to having a good experience afterwards. So we're pretty careful about the amounts we give you. Part of our anesthetic as well is preemptive anesthesia. We give you medicine actually before you have surgery to help with your pain afterwards. There's been a lot of studies out there that show if we start certain types of medicines before the operation, we can actually again decrease your pain after surgery. And another approach is using different types of pain medicine, which is the multimodal analgesia. We just don't pick one or two things, but we give you a lot of things. And what that lets us do is give you less of everything. So you need less of the medicines that make you sleepy, less of the medicines that make you sick. Found that this works quite well actually here. It also helps with your therapy the day of surgery or the day after surgery. One other thing that's important too to patients is most folks don't want to feel sick afterwards, and we We also give you medicines to keep you from getting sick. We can give you a pill that works pretty well, and we also give you some IV medicines, regardless if you've had trouble with anesthesia in the past. And we found that that works very well for folks after the operation. As Jennifer said, this is an operation. You are going to have some discomfort afterwards. The idea is we want you to be able to manage that pain and be able to do your therapy and participate in your recovery efforts. What we found with the protocol that we've developed is pain scores at 24 hours on a scale of 0 to 10 or 1 to 3 with what we recommend. Some folks do get a spinal but can't participate in the protocol because of allergies or other reasons. Their pain's kind of in the middle, 4 to 6, still not terrible. But occasionally some people just say, you know what, I don't want a spinal, I'm really scared of it. It's just not for me. We can do that, that's fine, but those patients typically have the very high pain scores, 7 to 9. And that's what we found here at Memorial, and that's what you're going to find out at other hospitals too. So really recommend the spinal if you're up for it, and hopefully you are, and it's really the way to go. One other thing that I would like to mention, and it kind of goes along with what Jennifer was saying about this being a center of excellence and having the Joint Commission come in and certify our program, is one thing that we've been doing for a while now on 4B, which is your recovery floor, the ortho floor, is we monitor you with a special type of machine called the capnography machine, and it monitors your breathing, even better than just having the little red light on your finger, which you're usually used to, which is the oxygen level in your blood. This thing actually measures if you're breathing or not. And it's kind of the hot topic now in anesthesia literature because people are realizing that maybe patients should have this when they're receiving the kinds of pain medicines you're going to get after surgery. We've been doing it now here for 3 to 4 years, so we're pretty far ahead of the curve, and I think that goes to show you that this really is a high quality program, and we do have really good results here. So the best part about working here, like Jennifer said, is that if something comes up different that we think is going to be better, we're going to try it and see what happens. The surgeons that are here that we work with, the nurses, the therapists, are all willing to try new things and see if they work better than what we have. And we have a great team to work with here, so I really enjoy doing this sort of thing and like doing these cases in the operating room. And my last point on there is kind of goes back again to what I was saying earlier, that folks are really worried about having a spinal anesthetic, but it certainly has no more risk than a general. In a lot of cases is a lot more safe for this type of surgery. So with that, I'm going to give it up to Dr. Adair, one of the orthopedic surgeons from the Springfield Clinic. And if you have any questions, certainly write them down. We'll stick around afterwards to answer them.
Okay. Yep. Scott's my anesthesiologist, by the way, in case you were wondering. So whenever I go to sleep, which is unfortunately more often than I might like for my various things, he's my choice. So I'm going to talk a little bit about. I guess it's a bit of a voyage that you're undergo when you get this total joint replacement. It's not just a single event that's just going to happen in one day. You get your total knee and it's all done. It's a little bit of a voyage. It's a 3-month deal. We think we have a pretty good roadmap here, and that's what this course is about, or what this talks are about, is how to get you through this pre-op period, the intra-op period, and then the post-op period, and have the best result that you possibly can, and the safest result that you can. So when we look at this as a roadmap of the series of events that we'd like you to do on your way through this. Not a single event, not just go get your knee replacement and it's all done. So some of that is you guys preparing. And since you're here, I assume you're preparing. Preparing mentally, physically, family-wise, getting everything ready. If you're prepared, you're going to probably have a safer voyage. The other thing is that this is a real team thing. It's a team sport here we're playing. You will encounter probably 70 healthcare professionals on your little trip through this. So it's not just about, these are the 2 greatest surgeons right up here. It's not just about them. It's a whole series of pharmacologists, of anesthesiologists, of physical therapists, occupational therapists, nurses. There's a whole team that you're going to be involved with, and that's our job, is to make this team work very well for you guys. So kind of focus a little bit on it's not just this one little event that you're going to go. It's about the whole little voyage that you're going to go. This is a good article from the New York Times. This is it was at the Academy of Orthopedic Surgeons. And what they did was they looked at a bunch of Medicare patients, and they looked at a bunch of people with arthritis. And they looked at the ones that had total joints and the ones that didn't have total joints. And I'm not sure if this is exactly true, but their study found that at 7 years after this, after the original diagnosis, that the people that had a total knee replacement had a 50% less risk of dying. So that metal is saving your life. Actually, it's what most of my talk about is tonight is your activity. And that's the whole point of this, is to make you active, so that you maintain your activity. Hopefully you live longer, but really we want you to live better, so that you're able to do more stuff, whether that stuff's getting out gardening, playing with the grandkids, playing golf. We don't care. Just go do stuff. So that's the whole purpose of doing the total joint, is to get you better so that you can be active. And this is just a study that was done of a whole bunch of people. And there are physically inactive and there are physically active people that they compared a variety of health issues with. And I don't know about you, but I like the physically active group a lot better than the physically inactive group. Whether it's cancer, diabetes, heart disease, hypertension, lung disease, psychiatric problems, stroke, all of them are less when you exercise. And this is only 30 minutes 3 times a week. So this isn't, you don't have to be like some crazy triathlete or something. So, well, that's a horrible looking guy there. This, I thought I was going to die. This is my first Ironman. And my wife thought I was going to die. And this is after I finished. And I really didn't know if I could make it to the hotel, which was about a half mile away. So 2 years later, this is me. Well, I'm happy. I'm finishing. I got my daughter with me. I'm a happy guy. Same distance. This one's harder. This was a much harder one. It's in the mountains. What was the difference between those two events, though? I was older. The course was harder. Well, the difference was I was prepared better. So that's what I'm going to talk to you guys a little bit about, is your preparation for this joint replacement. So if Dr. Ludwig does a joint replacement on me, I'll bet you he's going to bet that I'm going to do pretty good. If he does it on somebody who's a little more disabled or a little more deconditioned, they may well not do as well. Now, wherever you are is wherever you are, and you cannot change that dramatically. We all used to be fabulous athletes, able to run faster than Usain Bolt, but we're not so fast anymore. So starting where you are now, and I don't care, none of us care where you are right at this moment, you can improve. And that is what our goal is so that you get better, so that 2 things will happen. One is that you have less chance of any problems during the surgery. Your chances of complications, if you get vertical, the quicker you get vertical after your surgery, out of bed, you'll be better. You're laying in bed, taking pain pills, bad things happen. Vertical's good, up and walking. We'll get you up the same day, or we hope we can. And with Scott's help, we usually do. So what are some of the risk factors that we deal with pretty much on an everyday basis? The BMI, that's how heavy you are. A lot of our patients are heavy. It's hard getting that extra weight up after you've got a sore knee or a sore hip trying to get out of bed that first day. So that's an issue. Diabetes, 30% of Americans have diabetes. That's certainly a common risk factor we deal with. Nutrition is something that we don't think too much about, but probably about 20% of you people in this room are somewhat malnourished. So that's an issue that we can maybe think we can modify. Smoking, 20% of the people still smoke. We ought to fix that. Hypertension, arterial disease, and overall just general deconditioning from lack of use. And what a lot of us would like to use our knees, hips, whatever, for an excuse not to exercise, which it makes you have to modify things, but it doesn't mean that you can't do things. So all those things, Yeah, she's pretty good shape here. So all of these things are modifiable. So whether it's your BMI, how heavy you are, you can lose weight. Your diabetes, you can get under better control. By exercising, you can probably get your blood pressure better. You certainly can get your muscles, your balance, your coordination better so that you can stand on a single leg, that you can bounce back and forth, that you can get up from a sitting position better. More power, more muscle, less fat. More endurance, better balance. All those are going to matter because if you get up and get walking, right away your chances of blood clots, your chances of pneumonia, your chances of your bowel and bladder not working, everything gets better once you get up walking. So that's really the mission. And so those are the things that we want you to modify. Jennifer's talked a little bit about our First Steps class. This is a neat thing. It's free. It's put on out at the Y, the new Y, 5 to 6, first Wednesday of every month. A physical therapist friend of mine and I go through trying to optimize you, kind of going through the things you should do beforehand. Go to the dentist, get your physical done early, go see your heart doctor. John then, our physical therapist, goes through a lot of balance exercises, some endurance exercises, how you can physically get a little bit more fit. So those are the things we go through there, and we think, looking at some of our early data, we think that people are going to have a little better outcome if they go through that. That's certainly our thought, and it's pretty much supported in the literature. So the purpose of this thing is not to make us all look like Arnold. Arnold needs a little change as well. Is getting your body in better shape, getting your mind in better shape so that you're a little bit psyched up for this, so that you get up and you're ready to go, and your attitude does make a difference. If you lay in bed and complain and not happy, things aren't going to go well. If you're ready to go, you're energetic, you've got a good attitude, things are going to go better. And the other thing is, we talk a little bit about getting your family involved. They're going to be involved in this. Whoever gets their joint replaced is going to be a little grumpy. You're not going to be real happy. There's going to be some good days, bad days. You're going to need some pushing. You're going to need a little bit of encouragement from time to time. So that's kind of the thing that we look at from there. So I think hopefully this isn't right, but the rest of your life hopefully is more than 2 years. But it's just kind of a proportional thing where you look at this. These are relatively small periods of time, 4, 5, 6 weeks to get in better shape. And your rehab afterwards. Your hospitalization is a teeny tiny part. The rest of your life, so if you're walking around because you didn't do your therapy all gimpy, that's the rest of your life you're going to walk around gimpy. So it's really important that you guys really make every effort to maximize how this works. A, we don't want you to have any complications. And B, we want you to have the finest results you can. We want your motion to be good. We want your endurance to be good. Because we want you to go be active so you can be those people that live a little bit longer. So, if you do that right, your spring training is starting, and we'll all win the World Series and be happy. So, that's it for me. Dr. Ludwig's going to be next, and I've known Dr. Ludwig about 100 years. We came here just about the same time quite a few years ago. He's absolutely a fabulous surgeon. He works over at the Orthopedic Center of Illinois, and I'm sure he's going to talk a little bit about some of the technical things with total joints as they relate to you. So thanks.
Thanks, Dan. Great job. That was a good summary of how people should get ready for the whole experience. My task this evening is to talk about some innovations in total hip and total knee replacement. Some of this is more fun because I get to talk about technical issues that surgeons really enjoy talking about. Toys we get to play with, things like that. Some of it's a little difficult, though, because some of the innovations don't work out as some people have planned that they were originally designed to do. And we'll talk about a little bit of both of that. Before we get started, I would like to talk about just some general topics about total knee replacement. First of all, Medicare had a demonstration project on quality metrics a few years ago, and this hospital participated in that. It's called the Premier Hospital Quality Incentive Demonstration Project for Total Joint Replacement. And if you look at the conclusions of that study that was performed by Medicare, the top performing hospitals on quality metrics and total joints had these 4 specifications. They specialize in orthopedics. Memorial does that. They perform a high volume, just as Jennifer said, about 1,500 total joints are performed here a year, about 950 to 1,000 total knees, and about 450 to 500 total hips. Memorial does that. They were a teaching hospital. Memorial's a teaching hospital. And I know a lot of you are somewhat concerned when you come here sometimes about resident education, but really in a teaching hospital, you're going to enjoy the best care you can get because the residents are good residents. They take good care of you on the floor. They're well supervised, and all the attendings are pushed to stay up on all the most current things because the residents push us. So teaching hospitals are good places to get care. And finally, those hospitals that did the best were located in the Midwest, and obviously we're in the Midwest. So those are all good things that should make you reassured that you're coming to a good facility if you come here to have your care provided. The other thing I want to do is I want to give you a historical perspective. The current joints that we've been using for years give you about a greater than 90% 15-year survival rate. And the reason I bring that up is because we can have all kinds of fancy new toys and fancy new implants, but we want to remember that our history is pretty good and we don't want to screw that up. So the gold standard that we're using and been using for a long time is good. Those survival rates are dependent on proper placement of the components. And there's no substitute for experience in your surgeon when it comes to doing that. And there's no substitute for preoperative planning, not only by you by getting yourself ready for the operation, but also by us by planning the operation to put the proper implant in the proper position. The innovations that we're going to talk about tonight have either been designed to increase the survival rate of the implant or to reduce complications. And those are good things, obviously. And the other thing that I want to introduce you to is a concept called demand matching. Every doctor who does total joints does that. What we do is we look at the patient, your age, your activity level, somewhat your life expectancy, and we try to match the implant to that. So maybe someone who's 80 years old doesn't need a high-powered Ferrari total hip replacement like a person who's maybe 40 does. So don't be afraid of this demand matching. We all do it. And we're trying to just fit you with the proper implant that's going to provide you with the most efficient, best care, but also at the cheapest price. And price is becoming an issue in this country, obviously, with health care. Some general comments about innovations. We've already heard tonight about some new anesthetic techniques, some multimodal pain management techniques, accelerated rehabilitation programs, and these preoperative education programs. In my opinion, those things have made a bigger difference in my ability to provide care to my patients than all the technical innovations that we're going to talk about. Those 4 areas have made joint replacement, I think, much better than anything we're really going to discuss. So those are the things you really need to concentrate on, the things that the other people have talked about. And the accelerated rehabilitation programs have been a blessing, I think. I will make one comment about computer navigation. It's being used for both total hip and total knee. I think it's still an investigational tool. It's not really been shown to improve short-term results. There's still an issue with what I call cost-time benefit ratios. It takes longer to do it when you use the computer. It's more costly. We have to prove that it's better. There are other people on the panel tonight that have more experience with that than I do, so if you want to ask questions about it, I'd save them for the end. I think the bottom line is the jury's still out on computer navigation. Let's talk about some innovations in total hip replacement. I like to divide them into 2 areas. I think there's innovation in surgical approaches and there's innovation in components I'd like to discuss. The surgical approaches, I want to introduce you to a concept called MIS, or minimally invasive surgery. Maybe you've heard it already. And really, it's not the length of the skin incision, it's what's done underneath the skin. The surgeon is trying to limit the amount of trauma to the muscle, maybe going between muscle layers, cutting less muscle than we used to in the past. The incisions tend to end up being shorter, but really, again, the important thing is what's going on underneath the skin. Less trauma to the soft tissues means hopefully a faster recovery and easier rehabilitation for the patient. And really it can be done in 3 different fashions in a total hip. You can go through the back, a posterior approach. There's an anterior approach and an anterior lateral approach. And every doctor kind of has their favorite approaches. I think they're all good. And they've all been beneficial, I think, to the patients because of this less soft tissue trauma and faster rehabilitation. Then you have a component section. What are the things that have improved from a component standpoint of total hips? We have new bearing surfaces. We have new plastic called highly cross-linked polyethylene that has lower wear rates. We have things like ceramic, and we'll talk a little bit on metal implants. A lot of you probably have seen a lot of negative information about metal implants on the TV. There's lots of attorneys that have ads in the paper if you've had this hip or that hip and your hip's been recalled. Most of those ads are pertaining to metal bearing surfaces, so we'll touch on that just a little bit. We have larger femoral heads and acetabular inserts, so the ball and socket is now larger. That helps reduce the dislocation rate, so that's one thing that's reduced a complication that we used to have with total hips. The ball and socket would dislocate. The larger heads reduce that. And then we'll talk briefly a little bit about surface replacements, which is a type of metal-on-metal hip replacement that's designed for very young individuals. Okay, the gold standard is a plastic insert, so metal against plastic, a metal ball against a plastic cup. And that's worked very well for a number of years. Recently, the plastic's been improved to this highly cross-linked polyethylene, so the wear rates are very low. Because the wear rates are low, it leads to very low loosening rates, so that's been a very big benefit. In a younger patient, we may want to consider something like a ceramic bearing surface. You can put ceramic on plastic. You can put ceramic against ceramic, so the ball and the cup can both be ceramic. This is something that's very useful in young females that are of childbearing age. We don't do very many total hips on those, but occasionally we do. The wear rates with ceramic are very low because of the makeup of the ceramic from a physiologic standpoint, biomechanically. In this particular x-ray, this is a young lady who's 54 years old that has a ceramic on plastic hip in her left hip, and hopefully that'll give her 20-25 years of function with low wear rates, low loosening rates. So she's a good candidate for a different bearing surface. And again, this goes back to that demand matching. We have a 54-year-old woman. She may live for another 30 years. We need to provide her with an implant that may last that long. Someone who's 80 would not need that combination of implant surfaces. Here's an example of a larger femoral head in a 77-year-old male. These heads reduce the dislocation rate. It has to do with the ratio between the diameter of the head and diameter of the neck. Dislocations are a bad problem when they do occur after a total hip, and because of these larger bearing surfaces, we've been able to reduce the chance of, or the risk of that from occurring. So it's been a very positive innovation in total hips. I'm going to just talk briefly. I don't see too many young people in the audience, but there may be some active people that you know. This is an example of a 54-year-old male. He bikes regularly. He snow skis. He had bad arthritis. He wanted to keep doing a lot of those activities. He is actually a local physician. He's done a lot of research on his own. Was interested in this technique. It's basically designed for young males with osteoarthritis. Women of childbearing age, we don't do them on. People with metal allergy, we don't do them. If they have significant abnormal anatomy or very small sizes, we don't tend to do them on because of the patients that tend to fail early with the smaller sizes. And as we mentioned before, there's some joint registries in the world. One of them is in Australia. And the 10-year survival for these surface replacements in Australia is about 95%. So they've functioned well in the right patients. But again, demand matching. Not everybody needs something like this. It's a discussion you need to have with your surgeon about what's the best implant for you. I want to touch on this metal-on-metal thing just briefly. Again, there's a lot of medical legal issues with this, a lot of lawsuits that are pending on this. These are the hips that everybody knows as recalled. And I have patients coming into my office all the time. Do I have one of those recalled hips in my body, doctor? And it's a question that I think is a fair question, but by and large, most of these hips that have been problematic have been abandoned from the market. The companies have taken them off. The issue is metal ion wear, not only systemically. Sometimes these metal ions that occur from wear can cause systemic problems with your heart, kidneys. They can cause local soft tissue reactions, what we call pseudotumors. It's recommended that a lot of these people be followed with metal ion levels not only in their blood, but by doing tests like ultrasound or MRI to see if there are local soft tissue problems like these pseudotumors. The revision rates on these metal-on-metal hips have been as high as 20% or so, which is significantly higher than our standard hip replacement. They're very dependent on hip position, and sometimes they're implant dependent, meaning certain implants perform better from certain companies than others. Most of you would not require something like that anyway, and most of them have been taken off the market. This is an example of a 62-year-old patient of mine. He works out at YMCA every day. He's retired. The guy's a very active guy. He had this metal-on-metal large femoral head hip done on the left side about 7 or 8 years ago. It is one of the hips that's been recalled, but he's absolutely totally asymptomatic. He will not let me touch him. He's had an MRI. Looks completely normal. There's no soft tissue reaction. He's had some blood levels done for his ions. They're a little bit elevated, but not a lot. So not every one of these has been a failure. This one's been actually successful so far. But when he had his other hip done, he said he did not want that. So on the other side, he's got ceramic on plastic. So again, demand matching to the demands of that patient. Talk about some knee replacement innovations. Again, these surgical approaches, in my opinion, in the knee replacement realm, there is minimally invasive surgery that's available. I don't think it has been as big of a benefit as it has been in the hip. Most studies show some early benefit in strength, but long-term benefits are not as significant. Again, I want to emphasize, I think there's a larger benefit in total knees from the standardization of protocols, the accelerated rehabilitation programs, the anesthetic programs, the multimodal pain programs. I think it's a much bigger innovation than any kind of skin incision or type of approach in a total knee. There are some component issues I'd like to touch on in total knees. Some of them have been very positive, some of them have been negative, some have made no difference at all, and I kind of want to touch on them. And the reason I do is a lot of the companies are now doing direct-to-consumer advertising. You're seeing ads on the TV about this knee, the circle knee, or this perfect circle knee, or that knee. And the companies have learned that if they can hook you and you go to your doctor and ask for that, maybe it'll improve their bottom line. So let's talk a little bit about those. We're going to discuss a gender-specific knee, or what used to be called a female knee, a high-flex knee, some fixed and mobile bearing surfaces, and we'll discuss what that is. I want to talk a little bit about a new technique called custom cutting blocks, and then we're going to talk finally about some partial knee replacements. The importance of aligning a total knee to make it last for a long time, very important. And so a lot of these techniques that we're going to discuss is designed to do that. Okay, so gender-specific knee. About 5 years ago, there were a number of companies that came out that said, okay, we need to make a special knee for women. And there were some good design features in that knee, but most of the studies have not shown very much benefit thus far. And most of the implant companies have expanded the sizes of their standard knee to kind of fit most sizes anyway. So I think it's safe to say that by and large the female or the gender-specific knee is pretty much gone by the wayside. High flex knees, they were originally designed to gain more flexion or bend in your knee. Again, most studies do not show a great benefit to those when they've done comparison studies where one side had a standard knee, the other side had this high flex knee. The results at 1 year are pretty much the same. Same thing with a mobile bearing knee. And what I mean by a mobile bearing knee, if you look at that x-ray over there, you can see the thigh bone, the shin bone components. In between there's a piece of plastic that snaps into your shin bone component. That piece can either be fixed to the shin bone, meaning it doesn't move at all, it snaps in and stays, or it can be placed on top and it will rotate a number of degrees. And when you compare again those knees that have been done side to side at 1 year, the results are not a whole lot different. And again, I think some of this underscores the need for us to participate in this American Joint Registry so that we can identify which components really work and which ones don't. Which one are we having early problems with and which ones are we not? And we don't have that data right now in this country, but they are trying to collect it. The classic way of putting in a total knee is to put either rods inside the bone or we strap devices to the outside of your leg and cut off of that. So they're cutting devices that are either attached to rods in the bone, and that's the classic way to do it. And that's provided great results for the majority of patients that have had that done. It's still the most common way to do a total knee replacement today. And most patients do very well with that. But there is a new technique I want you to make you aware of. It's called a custom cutting block. It's not a custom total knee. The knee is not custom designed just for your knee. The cutting blocks are designed for your knee. And it's based off of a preoperative MRI or in some the companies a preoperative CAT scan. And what they do is that they make a piece of plastic that's sterile, that perfectly fits on your bone, it's pinned to your bone, and you can either cut through it or you put the cutting blocks into that device. And it's designed to give you a knee that's aligned better because it's done with a preoperative test, and then the computer analyzes that data and makes the device specifically for your anatomy. It's especially good if you have maybe some abnormal anatomy. You had an old thigh bone fracture and that thigh bone healed crooked. Then it makes it hard for us to put a rod up the bone and make the alignment good. So the computer can kind of figure out what that position should be. It makes the cutting block. You don't have to open up the inside of the bone. You just open up the knee, lay the blocks on. It's quicker to do, maybe cheaper. So there's a cost-benefit analysis that I think that we need to look at and see how that works. And this is kind of what it looks like. On the left, you can see ones that actually pin to the bone, and then the metal cutting blocks that we normally use fit into the plastic, and you cut through there. The one on the bottom is the shin bone. It pins to the shin bone. You put the cutting block inside the plastic, cut through that. The one on the right shows the thigh bone, and that's one where you actually pin the piece of plastic to the bone and cut through the plastic, so it's designed as a cutting block. So it is a newer technique. There are some people that are doing that on a routine basis. Someone like myself, I do them mostly on people that have abnormal anatomy. But it's, again, something you can speak to your physician about. I want to end by talking about some partial knee replacements. Not everybody needs every compartment of their knee replaced. We usually divide the knee in 3 compartments: the medial, the lateral, and underneath your kneecap. And we have partials that will provide replacement for any 3 of those. They do generally allow for some faster recovery because you're doing less surgery. The rehabilitation's quicker. We don't sacrifice as many ligaments when we do that operation, so the knee feels more natural to the patient. But again, you have to pick the right patient. You have to have isolated arthritis in just maybe one compartment. So this patient that's on the upper right-hand side has medial compartment arthritis or narrowing of this area, has no pain laterally, no pain under the kneecap, probably a good candidate maybe for a medial uni. This patient on the bottom has just arthritis under the kneecap, or what we call patellofemoral arthritis, and again we have a patellofemoral replacement that might be a benefit to that patient. And these kind of what they look like. This is a partial medial here where we've just replaced the inside part of the knee. We didn't replace the outside. We didn't replace the kneecap. This patient had a patellofemoral arthroplasty. We replaced what's called the trochlear surface, or the top of the knee or of the thigh bone, and replaced the kneecap with a plastic button. So that's what's called a patellofemoral arthroplasty or replacement. So there are partial knee replacements that are available if in the right patient. Again, it's a discussion you need to have with your surgeon. The last thing I want to say is this is my daughter taking her life in her own hands. She's wearing a Green Bay Packer uniform in New York where she lives at the Giants game. And this is my son. He doesn't give a dang about the big city. He just wants to sit on a rock in Colorado. So they're kind of different animals. So thank you very much. It's my pleasure to introduce Cal Sala. He's the division chair of the Department of Orthopedics at SIU School of Medicine, and he's going to kind of help us put all this together and summarize it.
While we're waiting for my talk to get up, I just want to say thanks to the audience for taking the time to be here tonight. So I'd like you to take just a second, and we'd like to applaud you for being here. My name is Cal Sala, and I have the pleasure of working with these gentlemen on a weekly basis. I consider them not only my friends, but they actually are my brothers in many ways, and people I rely on as to just shoot the breeze as well as go for advice and so on. They're just absolutely great human beings as well as great surgeons. But before I move forward, I want to just special thanks to this young man, Mr. Davis. Can you please just stand down there? Round of applause. He's the one that put this symposium together for the community. I really appreciate that. Evan is the backbone for this, and I just want to make sure. The reason the guys are laughing at the front because Evan absolutely hates any kind of recognition, applause, pat on the back, or anything. So one more time, let's give it to Mr. Davis. And of course, a special thanks to our speakers in the front. Absolutely the best and leading surgeons, and I would put them against anybody, not in just in our region, but also in the country. So a special applause to the speakers. I want to thank them immensely for their work together. Can you get the lights down a little more? I'm going to ask the lights to go down because I want to share with you sort of my experience of 25 years of being in medicine. And people, I'm not sure I want it down this low, people are going to go to sleep. I can't compete with these guys. Just maybe half of them. I'm showing a lot of x-rays, so I'd like you to I couldn't see them as well when the guys were showing them here, but I always get asked, what's the pillars of a great arthroplasty program? And I travel across the world giving talks and so on. And to me, it comes down to the people that make that program, working together to optimize the care, the network for that patient. It's all about the people. And this is what I hope to show you over the next few minutes. After doing several thousand of these procedures, I can tell you that at some point or another, we're all going to end up with a joint replacement. If you live long enough, 100% of us will end up with enough arthritis to need a joint replacement. It's not a bad thing, as Dan pointed out. It's a good thing. It keeps you active, and the whole point is to keep that cardiovascular system, your mind working, and every joint and muscle keep doing that. So joint replacement is a good thing. And in the past where we had approach this issue with patients by coming to them and saying, I'm sorry to tell you this, I've just seen your x-rays and your mom really needs a total knee replacement. I'm so sorry. Now it's like she needs a knee replacement. It's a new chapter in her life. She'll be able to reconstitute her function, be able to play with the grandkids, go out and take a nice walk with her friends. So it's a great thing, the total joint replacement. I think the numbers are pretty darn sure looking great for this procedure. The bottom line is, you folks, how many of you put your hand up if you have access to the internet? So it's about 85, 90%. That's phenomenal. I ask this question every time I give a talk like this, and every 6 months the numbers keep going up. And the bottom line is, access to the internet is a good thing, and it can also be a bad thing. Again, the information on the internet needs to be filtered, and we hope tonight that we've given you some information through the good presentations that we've seen. But the bottom line is, we're definitely living longer, we're more active, we definitely are not going to accept this getting old granny lifestyle. That's not acceptable. We want to enjoy our life, and we definitely want to be participants in our friends and our families and the people that we care about. This is a patient I call the future, but she's actually my patient. She came to me about 6 months ago. She's actually the nurse of another orthopedic surgeon in Chicago, had her other knee done. And if you look at here on the podium, you can see, I'm sorry, on the, over here you can see this huge binder. She had access to the internet, okay? And what you don't see on the chair beside her is another iPad with more information that she downloaded and didn't want to print. She had in there every known fact, more than even my mother knows about me. Every procedure I've done, every kind of publication I've had. She's gone to the national database and got patient satisfaction data on Memorial, on the region, complications, and she chose to have it done here. But this is our patient of the future, and this is what I think that we're all expecting, is we want this data. So one of the pillars of a great, successful joint replacement program, it comes down, like I said, to the people. And the key component here about the people we're composed of that support the patient is the surgeon, absolutely the hospital, the collaborative team that you heard about, as well as the technology. And each one of those are critical components to that success. So with your permission, I'm going to start with the first component, which is the patient. Dan did a great job of going over the critical component. To me, as a surgeon, I could tell you that I've learned the hard way, not just the easy way, but through multiple trials, that what the patient brings to the table, to the procedure, is so critical. That positive attitude, the exercise, the healthy, optimistic perspective, and that this is going to succeed, I'm going to do everything possible, I'm committed, I'm dedicated, only ensures success. Now, I'm sorry for this busy slide, but actually what it's showing you is what expectations that knee patients had for a knee replacement and what they actually got. And if you look at whether it's sexual activity all the way to improvability to walk, it actually meets them pretty darn close. The only thing it doesn't meet is the ability to kneel without pain. And we still haven't figured out that part, but it could let you do so many things, including social activities and the ability to go back to work and whatnot. So it's an overall, out of all the procedures in medicine, if you ask patients to compare them on surveys, joint replacement is number one. And it's number one for that reason, is because it does get people back to their lives. We do a lot of surveys with patients and a lot of studies that involve big centers. I can tell you that women, despite what the previous literature has said, do better than men. I want you to applaud the women, please, because we've done you a disservice. The reason is that in the past, and there's good documentation that showed that surgeons did not offer the same patients, because of gender, the operation for total knee replacement. And as a result, women did not get access to this procedure. But when the data started coming out and more studies were done, it showed that women improved more so than men. And their expectations actually are higher, and they're demanding, and they actually improve significantly more. Secondly, I think you heard today that less severe arthritis does better than more complex arthritis. And I'll show you some cases. So obviously, if you don't exercise because of the pain, your muscles waste. If they waste, then your potential of rehabilitation goes down and the potential of improvement goes down. So there's a fine balance that you need to work with your orthopedic surgeon to find exactly the right time for you to do that. Without a doubt, Dan hit this really nicely, that healthier patients do better than sicker ones. Obviously makes sense. And the most important part, and I want to show this through an example, is the mental component. That ability to have that positive perspective, the ability to come to the table and say, I want to make this work because this is a great option for me. This is an 18-year-old girl that actually had something called juvenile rheumatoid arthritis. And I remember this young gal who came, who's a university student, in a wheelchair. And you can see her joints are, I know it's pretty tough, but again, I don't know if we can dim the lights anymore, but you can see her, she's basically bone on bone. And she ambulates, and she has a hard time getting to most classes because some of the old buildings still have steps. And you can see that she's got destroyed hips. We replaced them, and she was able at least to walk with crutches within 6 months, and within the year was walking with canes. So joint replacement surgery at the various stages does have an impact, but it has to be, again, worked through with the patients, and that positive mental attitude, she was totally committed to having that outcome. This is a young gentleman, by the way, I have permission from all of these patients that I'm showing you tonight to do this, and they wanted to inspire and motivate other patients, so they allow me the privilege of not only taking care of them, but actually sharing their stories. This is a 46-year-old veteran who was actually in Desert Storm, who through a obviously traumatic event ended up losing on one leg, his one leg on one side, and then the other one had fractured significantly and multiple injuries on the right. And as a result of that, was completely disabled. As a consequence of this, he had a young child who was unable, who was born literally the year after he came back, was unable to spend time with him. His post-traumatic stress disorder was finally diagnosed, because at that time we didn't have good handle on these things. And he was in terrible, sort of dire straits, and unable to spend the time he wanted with his family and the things he wanted to do. This is what his x-rays looked like before the surgery. You can see that he had, this is the leg, the good leg, and you can see it's bowed, it's deformed. He had significant amount of hardware in there from the previously malunited or abnormally united bone. And I'll show you the scars, not just externally, but internally. So we went ahead and through the use of computer-assisted surgery, we were able to get through alignment. And again, I agree that computer-assisted surgery has its positives and its negatives, but I think at the end of the day, there's specific indications, and this is one of them, where you have hardware you have to deal with. And we got his leg straight, but he was committed to that success. What he brought to the table is this positive attitude that this is going to work, I'm committed to making this work. And afterwards, we were able to show him the x-rays, and this is what they look like. And he told me, Doc, I don't need the x-ray. I can see my leg is straight, I can bend it, I can move it, and within a couple of weeks, this is what he looked like. So in this video, here's his right knee. Again, he was completely disabled, this man in a wheelchair. You can see the scars, you can see his amputation on the left. You can see the scars here, and wait till you go to the other side. This man has been traumatized, like I said, not just physically, but also emotionally. And you look at the smile on his face. He was absolutely thrilled that he can get out and walk and spend time with his family. And that, as physicians, at the end of the day, we're humans too. And that critical component, what makes a great program, is human-to-human interaction. And it moves us. And if you think that doctors don't care, please come and spend a few hours in any of our clinics, and you can see the emotions that go in there. So I call this a moment of reflection because every patient brings a story. Every patient has a need. And for us, it's an honor and a privilege to be able to meet that need if we can. So some of it may rely on technology, some of it may rely on the surgeon, some of it may rely on the hospital. But at the end of the day, it's human beings coming together to form a network to provide that care. So let's talk about the surgeon. Dan and Leo did a great perspective on this. I think bottom line, there's nothing short of experience. It's been well documented that surgeons that do only joint replacement surgery do have better outcomes. Clearly, that's all they do. It's basically understandable that they have all the uniqueness to do that. And this is well documented, and below is the references. I know you can't see them, but I'm happy to share them with anybody. So the procedure has been nicely outlined. I think this shows it by pretty quickly here. I hope you don't mind. If you get down to the bones, this is the knee, this is the top bone, the lower bone. We make the cuts on each of these, and basically it's a plastic sandwich where we put metal on one bone, metal on the other, and the plastic goes in between. And that allows you to walk. So with time, the reason is are only been 90% so far, 15-year survivorship, is because that plastic may wear out. But the newer designs may even be longer than that, and we still don't know because we're still...
Yeah, all right. Again, go. Yeah, straighten it out.
And then back down.
All right.
And one more time. Up and
One more
down.
time. Okay, that's it. Now let's take a look at the scar tissue here.
She didn't want to be embarrassed by her colleagues. She had had this procedure, and you can see that she's actually not happy. She's unable to move it. She's had about 4 procedures after that, and she's unable to move it. If I showed you the x-rays, I don't know the technique, but that was not well done. And it was poorly put in.
Yeah, all right. Again, go.
Again, finding the right surgeon and working with them is critical to that success. Here's another patient. I think you can see this is a farmer's wife. She came to me because she had both knees replaced, and she wanted to know why is this one not working as well as this one. And I think you can see the incision is sitting to the side of her knee there versus in the middle. And if you go in here, here's her x-rays before the surgery. You can see the kneecaps are pretty arthritic. They're bone on bone. Her side knee, here's the front view. After the surgery, here's before the surgery, here's after the surgery. Here's her right knee. That's dislocated. So again, she went to another surgeon that wasn't doing a lot of these, and that component that did not go as well, that procedure. And I know that haunts some of you, and you talk to 1 or 2 cases.
Okay. Can you go to film? Yep.
Again, those critical pillars that we're talking about, you appear to them, you're going to have a great outcome.
That's it?
Yep. Can you follow the film? Show how it
Yes.
is?
Just bring it back up. Could you just straighten that back up again? Yeah. You see it actually just clunks back in. It's better almost going into extension actually.
I hope no one ever has to go through this process, and I ask you to do this right from the first time. How about technology? Technology definitely has been pointed out with Leo is, you know, it definitely has a component. But that technology is useless unless it has evidence-based science behind it and has been supported by the infrastructure within the hospital, within the medical community, and so on. As you heard, some of the implants that have been recently produced have had issues with them. So computer-assisted surgery, it definitely has been an advancement. Side effects have been minimal, if any. Navigation has been also shown to work in the hips. And this is a product of what technology can do. There's nothing wrong or against technology, but it has to be used in the right place, right setting, with the right patient, with the right expectations. This is another great lady. We just operated on her, but I met her a year ago, and it took us a number of times to get her ready for surgery, but she wanted to have the surgery. She has been unable to play with her grandkids, and you can look at here, and if you draw a straight line from her hip to her ankle, you can see that her knees are pretty deformed. Again, in a wheelchair. Her husband is medically, I would say, it's quite debilitated, and she provides the care for him, which has progressively become difficult. Again, another story, another human being, and she wanted to continue to provide that care. So, through technology, we're able to put 2 new replacements in her, and these replacements were allowed her to get, you can see the first operation, we've done them separately, the first left one, you can see nice straight leg there. And here's the other one, and here's the right one we did after that. So that deformity, it actually went out great. We corrected it. She was very happy with the results.
Bend it again?
Yes, bend it.
Operation. She's able to bend it.
Straighten it up.
And again, her husband, like I said, is not doing well.
Perfect.
He has on the
Thank you.
Able to provide care for him and do it at home. The options for implants is critical to have that technology, as Dr. Ludwig has pointed out. I think ceramics, polyethylene, and so on. It's critical that a hospital supports these. A lot of hospitals don't allow surgeons to have that access because they're costly, they're questionable. I think it's important to have those ability to do that. I showed you a knee replacement. I'd like to quickly show you what a hip replacement looks like. Regardless of which approach you get to the hip, bottom line, it's pretty straightforward. The arthritic part, again, we cut it. We do metal on one side and the cup side here. Plastic goes in between there, and then we drop metal as well in here, and then we put a ball around that. What you change is whether the plastic versus the ball. You can have that conversation with your surgeon. So bottom line is that technology, if it's not supported by science, by evidence, by long-term survivorship studies, I really caution you to just jump on board and be asking for the latest and greatest thing on the internet. And fully understand the risks as well as the cost for each of these procedures. So how about hospital? So I think that the bottom line, Jennifer's done a great job about the great program that exists here at Memorial. It starts with, again, people, and it ends with people. For me, education is a critical principle of that interaction. Me exchanging information with you, understanding what your needs are, and doing the same thing by getting that information back. It's critical to have a hospital that is experienced, that does the volume, that is able to reach out and say, here's how we can help you meet your demands and expectations. And it doesn't just stop, as Dr. Adair pointed out, with just the doctors. It goes beyond that, the nurses, the OT, the PT, the pharmacists, and so on. And I think the study that Dr. Adair quoted, with some 70-plus professionals will be touching you or your loved ones, speaks to the fact that this is a network. Again, human working with human to provide care for the other. The hospitals provide the environment. And the number one complication that occurs as a result of joint replacement is infection. In that, in terms of its impact, that's what I'm calling number one. But the operating room, the nursing staff, the precautions incorporated, the post-operative care is all created and supported by that hospital. It provides that care. And yes, more studies have shown, multiple studies have shown, hospitals that do large volumes, such as Memorial's, have way better outcomes because they could do it more efficiently, cleaner, and less complications with better expectations for patients. Host of things can be reflected in terms of surgical site infection. What is infection? And I'm not going to go on these, but again, the hospital plays such a critical role, and a hospital having the access to resources to provide that care because they do large volume of these cases is important. Now, how are you supposed to find out this information? Well, believe it or not, I'll give you the websites, and they're right there. Who has, again, the internet? Put your hand up. All of you can go on these websites and you can get that information. You can see how well we're doing here at Memorial. It's really phenomenal. Finally, collaborative team effort. And this is really the sort of the foundation for me that puts this all together. One of the things that we have is the co-management team where orthopedic surgeons meet on a monthly basis, looking at every process we have and seeing how we will. I know I'm not as pretty as Dr. Adair, but I think, you know, or Dr. Ludwig. But bottom line is, these are really top-of-the-notch guys that are doing what they can based on the best information we have to bring the best care to our patients, bottom line. So if you ask me again, what makes a great best joint replacement program? It's the people. And the people as surgeons, hospitals, team effort, and technology really put it all together. So with that, I'm going to turn it over to our colleagues, and I just want to end up with one final case. This is a 65-year-old male man, was ready to be fired because he's been taking off so much work. You can see his right knee is pretty arthritic. And if he didn't have anything done, he was going to basically retire and call it a day. But he didn't want to. He enjoyed his work, enjoyed carrying mail, and wanted to continue that. But if you look at his knee, you can see it's sort of subluxed, or what we call subluxed. It's almost dislocated off the other one. Significant deformity, and he had significant disease since he was a child. So we went ahead and did his knee replacement. Again, we used a stem because it was osteoporotic. Dr. Ludwig, it's not because I believe it's...
Like it, don't like it, and we'll do these little things here.
That's the maximum, right?
Yep. Our drill bit.
Varus valgus.
And then this thing, that mass.
Check the stability.
Oh, you got a picture of that?
Yeah, we got for 3, 4, 5.
I think he's videotaping.
Taping. That's taping. Varus valgus. Yep.
So then we'll do that, and this will go on.
No opening, right?
Right.
And these are the incisions, all ones.
Go back to work. Here's how we looked like after surgery.
Okay. Push as much as possible. Oh, perfect. Stability. Inflection, please.
This man did go back to work within 6 weeks and is not losing his job, despite what's going on. So I thank you again for your time, and I'll turn it over to my colleagues. I want to thank you all for being here, and Evan, thanks for putting this together. Thanks, Jennifer. Want to go up here or want to? Okay. You guys going to make me stand by myself here? They're hiding out all in the corner there.
I saw on a billboard not too long ago advertising robotic hip and knee replacement. Could you explain that?
There's a company called Mako that has provided a robotic arm that is sterile, that is brought into surgery. Right now, I believe they've had approval for partial knee replacements of the patellofemoral joint and the medial and lateral compartments. And they've also have approval for assistance in placement of the cup in a total hip replacement. To be honest with you, the hospital down the street did buy that robot. Our co-management team here decided that maybe that wasn't the best use of funds. It is something that is available in the community now. I don't have any experience with it. I've been to their training facility and used the device. I think it probably has uses in the right patient, but those are the 3 areas where they've had approval for partial knee replacement of the medial lateral compartment, patellofemoral joint, and then for assistance in placing the cup portion of a total hip replacement.
But is there any evidence that it's better, more superior?
Well, there's no...
Putting Leah on that spot.
There have been no objective studies that compare it to standard techniques that show any difference in the procedure. So like a lot of the slides I showed you during my talk, and there are some company representatives in the back, I don't want to make them too mad, but companies tend to bring up things that technologically make sense and look really good, but some of it's also marketing. I mean, let's be honest. McDonald's wants to make their hamburger look better than the hamburger that's on the billboard that Burger King has, because they want you to go to McDonald's and buy that burger. So there's some marketing going on in orthopedics right now, and the reason is the demographic play. You're all getting older. You're all going to need total joints replacements, like Dr. Salas said. So these companies are out trying to get your business, and so you're going to see a lot of marketing. And what I recommend in those situations is that you pick your surgeon depending on who you want to see, and you speak to that person about the technologies that are available and which ones are right for you and which ones aren't, rather than looking at a billboard. Did everybody hear the question? So by delaying joint replacement on one side, are we making our other joints worse? Okay, I'm going to let Dr. Sala answer that.
Oh, thanks, Leo. I love you too. Thank you. I'm going to give this to, I think it's a fair question to ask. I could tell you that the science, if you want to go there, absolutely shows that if you are going to offload one joint, you're going to double up the joint. The other joints are involved, not just the hip on that side, but also the hip on the other side, and actually your other knee, because it'll be doing the work. At the end of the day, though, it's a balance between when to do the surgery versus and waiting for the muscles, if you're not using it, to atrophy versus moving earlier and doing that knee replacement or hip replacement. And that only can really come as that exchange between you, the surgeon. I rarely book patients for surgery right off the bat unless I know them and we've had exchanges and I know what the technology can provide and if it can meet the expectations of the patients. So that would require quite a discussion, maybe involve some adult beverage between me and you during a clinic. And that, but bottom line is that interaction, is this going to meet your requirements? And as what Dr. Ludwig's pointed out, and we're joking, but at the end of the day, that demand matching is critical. Which implant can meet your expectations? So that only is going to occur at some point where you're going to deteriorate. You are losing muscle mass. If you do what you're doing, every day we get older, we lose protein and muscle mass. The question is, are you losing it faster because you have arthritis and you're not using it, what we call disuse arthritis? That's a problem. Then I think you need to start talking to somebody and saying, when am I ready for this? And can the technology meet my expectations?
Believer in that. I think it's beholding upon you all to get yourselves in better shape. If you want a better result, at the end of the day, if you're gimping around in a year, it's your knee and you're gimping around. So yes, I think if you want physical therapy, all of us would be more than happy to send you to physical therapy for a few sessions. I would also encourage you to join the Y, the Fit Club, or some place where you can go work out on a regular basis. Because ultimately, going to physical therapy 4, 5, 6, 7 times isn't going to make much difference. It's ultimately going to be you working out for a period of time, 4, 6, 8 weeks, longer the better, and go from a deconditioned state, wherever you are now, it is what it is, and get in better shape. So anything that you can do to improve yourself will make a huge difference at the time of surgery. So yes, we'd all be more than happy. We all love to have well-conditioned, healthy patients come in. It makes our life infinitely easier. Yes, ma'am. Red. I'd like to let Dr. Satobi, the anesthesia. Phil, you want to do that one? We'll just go back and forth.
Well, let me ask you a question. Are you getting regular follow-up from your surgeon? Oh, you left town. Okay. Well, I mean, our academy recommends you don't need follow-up every year, but you should have follow-up every 2 to 3 years probably. I mean, I like to see my patients for the first year, then I see them at maybe 3 years, or 5 or 6 years, then 10 years. You want to see them once in a while and get an x-ray. And what we're looking at, as Dr. Sala said, is that piece of plastic is the critical component in most people. It's between the metal components, and we want to check an x-ray and see what the thickness of that is in layman's terms. There's also some wear things that you can see in the bone where some of those particles can get in the bone and cause some destruction, and what we call osteolysis. And those things can be picked up on x-ray. That's why it's important to get regular follow-up of your total joints on an occasional basis. Get an x-ray, have your doctor critically look at those films. To get back to your question, her question is how effective is revision surgery, if I'm quoting you correctly. If you've got bone to work with, and that's why you want to get that routine follow-up so that you don't get to the point where there's not a lot to work with. But if there's still some structurally good bone to work with, revision surgery can be very successful. The risks are a little higher, the infection rates are higher. It may take you a little bit longer to get over the procedure. But by and large, people do very well with revision surgery. I did not talk about revision components because it's a big area, just separate from just primary joints. But the results are very good because the technology we have in that particular area is fabulous. I mean, the things that are available for revisions of knees and hips is great technology. It makes the job much easier than it did 20 years ago when I was still trying to first do so. So they can be very successful, but I think the important thing is you should get regular routine follow-up from some orthopedic surgeon on a regular basis, get some x-rays, get an examination, so that somebody's following that joint to make sure that you don't get to some critical point where we can't help you. Yes, ma'am.
So as you can see, the guys dumped this question on me. All right, so I'm going to go to my friend who is actually as well my personal anesthesiologist, Dr. Satovia, because I'm getting older and I had a few procedures that he did for me. Scott, we're going to start with you.
Yes, you can still do this one. Actually, most folks get on some degree of spinal stenosis in there.
So the question, bottom line is, hip replacement is probably, the rehabilitation from that is a lot easier, I think, than knees, and I think my colleagues on both the right and the left would agree with that. Most patients are up, as Jennifer pointed out, that afternoon, at least sitting up, if not walking the next day. In terms of how we get into the techniques of what we put down in there, I really tell patients you're welcome to ask questions, but I don't want you to get lost in the details. I know that when we're in there doing a hip replacement, to me, you become, please don't laugh at this, it's called bone whisperer is what I tell the residents. You really got to look at that bone, understand the anatomy, understand what it can do and what it can't do. Our preference is to do an uncemented hip replacement where we put it in and let the bone grow into it. Sometimes the bone shape, the quality of the bone, there's osteoporosis, previous injury, may not facilitate that. We may have to cement. Having said that, the outcomes are superior in either one, and really there's no difference, and both have shown well above 20 years success. So there's some things I would bother and sort of say, I need to know what you're going to do. Well, it's kind of tough. I tell you that if a surgeon can tell you exactly what they're going to do in surgery, they haven't done enough joint replacements. They have been humbled. They haven't been on their knees, understanding that the complexity that can occur during any case, despite the best laid down plans and having faith. You walk in, sometimes that hip is going to give you nothing but trouble, and you got to figure out how to negotiate to get the best outcome for that patient. So the answer is either one works well. Try not to get bogged down in the details, but ask your surgeon just what kind of implant after the surgery ended up putting in. You can share your preferences, you can ask for the science, but at the end of the day, I know that the surgeon's going to do what's best for that particular bone. Does that make sense? Embolism, as in clots, I think that's a great question. I'm sorry, the emboli, so basically what we call clots that can potentially deep vein thrombosis that can go potentially to your lungs. Those are really huge and a big issue for us, and it starts with Scott. That anesthetic that he starts with actually declines or decreases the potential for producing clots because what causes is it causes venodilation, which means that the blood doesn't sit around with a spinal versus a general anesthetic. Two, because you're not completely out, you get up and get going right away, and that's why Jennifer has you walking, if not sitting, at least that afternoon. And then you have multiple factors that we put in there, including the activity, patients doing activity in bed, when they're sitting, when they're standing, physical therapy twice a day in the hospital, and we use medications to help you with that. There's pumps as well that we use to move the blood, but at the end of the day, that works extremely well to get the blood moving. Yes? That's you.
That's way too hard for me.
I think that you'll see that hospitals aren't stupid. They're like the implant companies. They see that the population's getting older. We saw a graph there about how we're all getting older. There's going to be 50 million people over age 65 maybe by 2030. So the hospital down the street is also working hard, I think, to improve their total joint program. I do work at both hospitals. I work more here than I do there, but I do work at the other hospital. Oh, sure, I do some cases. I do cases over there.
No, you can't take Scott there. No.
Scott stays here. He's loyal to this campus only. So, in fact, if he tore his shirt off, it says MMC across his chest. And it says Superman on the back. So. But go ahead, sir.
Tough one.
Did everybody hear the question? Having both knees done at the same time?
If you look at that, there's some people that clearly should do one. And if you're sick, if you have heart trouble, if you're over 80, you should clearly not even entertain it. If you begin to look at the other people, as Dr. Ludwig says, I don't know who he's talking about. He said, "You guys are getting older." I know how old he is, and I'm one of you guys. But doing two at once probably has a slight increased risk of complications as opposed to doing two. You can look at those numbers and you can kind of question them some. I guess in my mind, if you are a tough guy, you can convince me you're a tough guy, and you think that you're able to get up and get going right afterwards, it does make a little bit of sense to do two at once. But you have to be kind of a special person. You got to be in good shape. You got to be willing to get in shape. And you got to be a pretty tough hombre after that surgery to get up and go. And it is by no means an easy task to rehabilitate from two total knees. So that's a tough one. I guess I don't know about you guys, but I think most of us will do it on a relatively rare occasion.
So that basically what Dr. Adair just said. That takes out all the men. Out.
Yes, ma'am. Red shirt.
I would still say a spinal and nerve block is probably okay for that, because you're going to have a higher risk of complication no matter what type of anesthesia you have. If you have a general anesthetic where you're on the ventilator for a little bit during surgery, you have a higher risk of not getting off the ventilator at the end, so that increases your risk there. You probably have a little higher risk of maybe having some minor nerve damage, and usually that would be maybe a numb leg, patch of skin for a few days or a few weeks after the operation from the spinal or the nerve block. But either way you look at it, your risk of injury or complication is a little higher with either a spinal or a general. So again, with the other benefits of the spinal, I would say that's the way to go.
You know, blood clots, again, the questions is again about blood clots, and that is a scary thing for all of us up here. And by you getting in better shape, and maybe I'm harping on that a little bit, but if you can get up and get walking, that's going to decrease your chance of getting a blood clot. So that's number one. Two is if you select and do the appropriate anesthesia, that's number two. Three, if you're just willing to move afterwards, you know, if you are paranoid and you are moving your toes and you are wanting to get up, that's going to make a big difference. And three, pharmacologically, which is not the end-all, be-all, cure-all, we will pharmacologically thin your blood as well after surgery. So there's it's kind of a multiple ways of attacking that problem. What you can do is get yourself in great shape beforehand, get some of the swelling down out of your legs, get your muscles so they work so that you're ready to rock and roll afterwards. Force yourself physically to get up and go right after surgery. Pick the appropriate anesthesia, and then we will give you the pharmacological means necessary to thin your blood. So yes, there is a risk. We keep it very, very low. The incidence of pulmonary embolisms, blood clots is markedly lower than it used to be. If we do nothing, it runs about 50%. So it can be very high, and that's the real worry. But if we do everything appropriately, your chance should be way, way, way down low. There's very little question that we all are pretty advocates of the spinal anesthetic. We don't insist on it, but we strongly urge our patients. And why? Because you do better.
You mean preoperatively you're already on blood thinner? Okay. Well, we deal with that situation all the time because we have lots of patients with cardiac disease or history of blood clots in the past. And all of our patients are sent for preoperative clearance with their family doctor or their cardiologist, and we communicate with those physicians as well. Usually your blood thinners would be stopped a certain period ahead of time. If it's Coumadin, it's usually stopped about 5 days ahead of time. Plavix is another blood thinner. A lot of heart patients are on with stents. Personally, I like that to be stopped about 7 days ahead of time. We fight with the cardiologist because they don't like to stop it that soon. Sometimes they'll say 5 days. Low-dose aspirin, I don't know what the other people in the panel are. I think we're pretty in agreement with that. I don't stop low-dose aspirin at all anymore. A lot of the cardiologists don't want you to stop that if you have stents in. So I'll usually not stop low-dose aspirin, like a 81 milligram aspirin. But basically the anticoagulation is stopped prior to surgery for a specific period of time to allow your blood to reverse itself. And then either the night of surgery or sometimes post-operatively we restart it. But it's an issue that we all deal with on a regular basis. Okay, so I don't know your individual case, but there are some situations like cardiac problems where the cardiologist wants you on some sort of blood thinner, you know, persistently, even though we stopped the oral blood thinner, so they may put you in the hospital, put you on IV heparin or low molecular weight heparin, one of these injectable, you know, agents that thin your blood. So your situation may be different than just the average situation. So in your situation, they put you on something that's IV. They stop that like 6-8 hours before the surgery, then do the surgery. So it may be a little more complicated in your situation. Saying for prophylactic purposes to prevent a clot, or if you got a clot, how long would you be on it? Okay, so prophylactically to prevent a clot, I think most people, if they treat you with postoperative Coumadin, would have you on Coumadin for anywhere from 4 to 6 weeks, which would require some blood draws to monitor that.
But if you're already on Coumadin before surgery, you will be maintained on Coumadin after surgery. If you're on Coumadin before surgery, once we finish the surgery, you'd be on, there'd be no difference. You would continue on the Coumadin after surgery. Okay.
Ma'am, one last question?
Last question, all right.
I'm sorry, so can you frame your question so everybody can understand it? All right. Sure, so if you look at patients in general, they develop arthritis not just on one side of their body, they develop it on both sides. So yeah, it sucks to get old, right? Who can tell you that from our side? But that's right. So we have a saying that people heal better with metal. That was just joking. But the bottom line is that most patients develop arthritis on both sides. And what's going on is basically that joint is probably wouldn't have lasted that long had you not had your knees replaced and the other hip done. So it will do, as you have already a hip and a knee already on the other side, I don't see what would be the difference between them. 90% of patients will have arthritis probably comparable on one side to the other, 90%. So. Sorry. That's the whole point. That's the whole point to keep you going. I think that statistic that Dr. Adair showed is bottom line. We're making patients live longer. I mean, if you think about Medicare, 1964, right, that's what the politicians are talking about, came into board because patients were expected when they retired at 65 would live maybe 5-10 years after that. Patients on average in this country, on average, that means there's a lot more living past that average, are living to 85. And joint replacement is a big component of that. That activity is critical to living longer and actually happier because you're able to do the things that you want to do. The integrity to do things for yourself without having to bring family members and that kind of thing. So I do agree with people heal better with metal kind of saying.
Well, I think we'll go ahead and close it up. Appreciate you all coming.
If you have a comment about tonight's presentation, if you wouldn't mind filling out this card, or if you have any ideas for future topics, what's interesting to you, there's a little metal basket, a silver basket on the back table. If you just leave those in there, I would really appreciate it.
And Jennifer's kind of the glue that holds the whole program together. So if you have any questions, call her.